When it comes to ADHD, can the answer be found in just one piece of the puzzle? What if the piece doesn't fit, or even worse, complicates the picture? Let's think about 3 individuals. The first individual responds to a stimulant. The second does not respond to a stimulant. And the third worsens with a stimulant. All 3 of these patients may or may not have ADHD. And that's what I'm going to take you through today, is that the treatment of ADHD is not equal to just a response to a stimulant. The treatment of ADHD goes beyond stimulants. Even patients with a diagnosis of ADHD may respond to a stimulant, may not respond to a stimulant, or even worsen with a stimulant. And that's the ADHD puzzle we face on a day-to-day basis in clinical practice. Hi everyone, I'm Dr. Sanil Rege, consultant psychiatrist. Welcome to Psychiatry Simplified, where we cover all things psychiatry and neuroscience related. So if that's your thing, don't forget to hit the subscribe button to keep in touch with all the future releases. Today we debunk a common myth. ADHD is not synonymous with stimulant medication. ADHD as a condition cannot be reduced to just stimulant responses. So let's understand this in a bit more detail and go beyond the stimulant bottle. You see, research paints a startling picture. In the short term, stimulant medications help. However, over the long term, naturalistic studies have shown up to half of the individuals may stop taking the medications, mainly due to side effects. When I talk of stimulants, I mean 2 different molecules. One, dexamphetamine, which comes in the form of Adderall, or long-acting lisdexamfetamine, which is Vyvanse. There are, of course, other formulations. However, the base molecule is an amphetamine derivative. The other one is methylphenidate. Now, I've covered the differences between these 2 in another video, so don't forget to check that out. When we think about ADHD as a condition, it's important that we deconstruct the condition into the various domains. So what are these domains? First, cognition, a key component which is executive function. 2, activity. Here we see motivation and hedonic drive. 3, reward learning. 4, behavioral inhibition, which is really the impulse control. 5, behavioral activation. And 6, the fight and flight response, which is really the core of the stress response. So what you can see here is through these 6 domains, we cover the frontostriatal limbic circuits, which essentially help us as human beings to function. And we know that one of the core abnormalities in ADHD is dysfunction in the frontostriatal limbic connectivity. So therefore, we can't afford to just focus on the prefrontal cortex or the striatum, which of course relies on dopaminergic and noradrenergic potentiation, which is what we try to do through stimulants, but we also need to take into account the limbic part of the brain, the emotional arousal part of the brain, which really is mediated through amygdala activation. This is why emotional arousal, emotional regulation also forms a crucial part of the ADHD treatment. And here we've got to start thinking broader. So whilst we carry out specific questionnaires and rating scales, it's important that we look at symptoms in each of these specific domains. With over 127 permutations and combinations in presentations, it's clear that one size cannot fit all. So therefore, in making a diagnosis, we have got to consider the diagnostic elements across all of these domains, but at the same time look at the various factors that affect these domains. So let me give you an example. One crucial domain that's often overlooked in treatment is sleep. ADHD is highly comorbid with sleep disorders. Some research shows that the comorbidity is up to 80%. So what happens here is we know that in the short term, for many patients, a stimulant can improve sleep. A stimulant can improve many of the other domains: cognition, activity, behavioral activation, impulse control, emotional regulation, including sleep. However, there is a group of individuals where the effect of the stimulant wears off, or they might find that the stimulant worsens their sleep. This is the group that we're talking about. This is where we're trying to highlight that ADHD treatment isn't just about stimulant, because in such a case, simply increasing the dose may not address the problem. That's why we've got to start thinking outside the box. For example, in children, sleep breathing disorders, particularly associated with tonsils or adenoids, can play a part affecting all of these domains, sleep, but also cognition, activity, and the other domains. In such cases, addressing the enlarged tonsils or adenoids may provide greater efficacy for the medication to act. This is not uncommon in clinical practice. In adults, for example, in clinical practice, patients sometimes respond to stimulant treatment at the start. However, after a few months, say 3 months later, they come back and say, "Doctor, the stimulant stopped working."
Oh no.
At this point, it's important that the clinician stop and ask, what does the patient actually mean by the stimulant stopped working? This is where patient phenomenology becomes important, their descriptions. For example, if a patient tells me that it stopped working and I delve deeper and I find that it's actually their sleep that's worsened, which is affecting executive dysfunction, then I've got to focus on the sleep aspects, because in such a case, simply increasing the dose may actually worsen the situation. Similarly, if I find that they tell me that their thoughts have started racing, then those racing thoughts may actually impact on cognition. Now, this is not to say that increasing the dose may not address this. However, one has to be cautious because there may be an underlying alternative disorder, such as a mixed state where a stimulant increase could worsen the state significantly. What I'm trying to highlight here is that rather than simply increasing the stimulant dose, which is one strategy, one has to take a step back and consider the factors that have led to the stimulant most likely to stop working. Now, in order to do this, one has to employ a structured approach. I've covered the diagnostic evaluation of ADHD in another video, so don't forget to check that one out. If you're a clinician looking to master ADHD in clinical practice, then check out our Academy course, the Clinical Excellence in ADHD Curriculum, a 13.5-hour journey with structured interactive learning, quizzes, case studies, video lectures, and literature, all synthesized in a comprehensive package so that you can make the most of your learning and apply it to clinical practice. So let's jump back to the video. Here we employ a diagnostic hierarchy. We start off with organic factors. So we look at all the multiple medical issues, for example, iron deficiency anemia, obstructive sleep apnea in adults. I mentioned tonsils, adenoids in children, and a range of other factors, hormonal factors, for example, in females. Next, we look at substance use and medications. Could the medications, not only stimulants, but other medications that are co-prescribed, that could be associated with worsening? Next, we look at the mesolimbic activation phenomenon to see whether there are conditions such as mixed states, hyperarousal, significant sleep difficulties that might be playing a part. The next level down, we look at the affective component. Here we look at the frontostriatal circuits, but mainly from the lens of depression. Could depression be playing a part? Because here, the cognitive element is not just executive dysfunction, it also includes the emotional appraisal of situations, which requires that slightly different approach. The next level down is trauma, both current stresses and past trauma. Here we look at the stresses such as relationships, accommodation, finances, vocation, etc. We also look at conditions such as eating disorder and OCD. And finally, the lowest level of the hierarchy, we'll look at coping strategies, whether personality factors are playing a part here. Once we go through a structured diagnostic hierarchy, now we widen the lens so that we can look at the various factors and address them accordingly, allowing the medication to work effectively, or considering augmentation strategies that provide targeted treatment. You see, ADHD as a condition is like an iceberg. What one sees at the top of the iceberg is often the obvious aspects. However, there might be a lot lurking beneath the water. Here, one has to look at a number of aspects. I mentioned sleep, but there could be pain syndromes, there could be mood syndromes, there could be personality factors, there could be organic factors, medical factors such as immune dysregulation, allergies, inflammation, etc., etc. So the message here is the clinician has to look at both the top of the iceberg, but also dive deeper and look at all aspects around the iceberg to address the issue effectively. For example, if I identify sleep apnea, a referral to a sleep physician with a CPAP intervention could allow for the stimulus doses to be lower as well, as the CPAP allows for better brain perfusion, minimizes hypoxia, thus improving cognitive function. When there are significant sleep disturbances or hyperarousal aspects, for example, nightmares or vivid dreams, consideration of agents, non-stimulants such as alpha-2 agonists such as guanfacine or clonidine may be more appropriate or can be considered as an augmentation strategy. Let me give you another example. For instance, in females with ADHD have a predominant emotional arousal model, and thus often one finds that agents such as dexamphetamine can, in some females, be excessively activating. They may notice benefit in the initial stages, however, later on, they might find that the medication is too activating, resulting in increased anxiety or in some cases cognitive rigidity, OCD type symptoms. This phenomenon can also be found in individuals with post-traumatic stress disorder and complex post-traumatic stress disorder with comorbid ADHD. Thus, it's essential to tailor our treatment to the specific symptom domains. We know that ADHD is a lifespan condition, and therefore treatment effectiveness should be evaluated over the long term. Therefore, for the clinician, the choice of medication or medications, augmentation strategies should be considered with a view towards improving the patient's function over the long term. As I mentioned, whilst many patients may improve initially, they find that as time goes by with increased stresses that we all face through life, they find that the effectiveness of the medication wanes or they experience side effects. And this is reflected, as I mentioned at the start, in the adherence rates. There is a significant non-adherence to medication with a major proportion due to side effects. Why does this happen? Let's look at the neuroscience behind it. This activation or worsening over time with increasing side effects happens because stress. And when I say stress, I don't just mean a negative event. What I mean is a daily load on our brain to solve problems, to address the challenges that we have through life. So this happens because stress acts as a dose increase, because positive or negative stress activates the amygdala. That is the default mammalian stress response. And the activation of the amygdala acts as a dose increase because amygdala activation results in increased dopamine and noradrenaline. Now, when you combine these two, the increased noradrenaline and dopamine, along with the medication which is already potentiating dopamine and noradrenaline, it's like an increased dose on its own. And this is why over the lifespan, we've got to look at what are the changes occurring in the person's environment and what are the changes occurring in terms of the symptomatology, and then adjusting the two over the lifespan. So you might say, well, Sanil, why not just increase the dose? I've covered it in another video as well, but the prefrontal cortex operates on a Goldilocks principle. Too little, and there are symptoms of ADHD, executive dysfunction, hyperactivity. Too much, and one has stimulus-bound responses, increased anxiety, increased hyperarousal, but importantly, a worsening of cognitive function, where the individual moves from cognitive flexibility towards cognitive rigidity. And this makes decision-making difficult. In some cases, adults can present with obsessive-compulsive symptoms or repetitive thoughts, very similar to what happens in children, like tics. But in adults, here you get tics in the form of thoughts, repetitive thoughts that impact decision-making. And that happens because the dopamine and noradrenergic potentiation has gone towards the opposite pole, which is not functional. So this leads to excess activation of the D1 and alpha-1 receptors that then lead towards cognitive dysfunction. So as you can see, there is a lot more to consider in ADHD treatment than simply reducing the condition to the prescription of a stimulant. ADHD treatment is not just about dexamphetamine or methylphenidate. It is much more. ADHD is a highly comorbid condition, and in order to be a true expert in ADHD, one has to be an expert across all aspects of psychiatry and across the lifespan of the individual. So I hope that this video has given you a broader understanding of the condition we call ADHD. If you found this video useful, don't forget to leave us a like. A big thank you to all of you for supporting this channel. It really means a lot to me. And thank you to all of you for your comments, your questions, as they provide a lot of food for thought for me as well. I look forward to seeing you in another video soon. Until then, stay curious. Bye-bye.